Whoever is coming, please admit.
Yes, madam. Yes, madam.
Thank you, Raj. You can
Yes,
start.
madam. Yes, madam. Record ஆகுதில்லையா? இது ரெக்கார்டு இருக்கு, பாஸ் இருக்கு. பாஸ் ரெக்கார்ட் ஆகுது. Okay. So, very good morning, one and all. First of all, I would like to thank Professor Meenakshi Madam for inviting me to discuss on basic and advanced pleural interventions. That is one of the bread and butter for most of the interventional pulmonologists. So sorry for the delay, first of all, because of technical issues. So I just want to connect a lane to the laptop instead of Wi-Fi connection, which will be a better option. But there was some problem in that, that's why. So without wasting much of time, so we'll go directly to the topic. So what are the common pleural interventions that what we do in day-to-day practice? The very simple one, starting from thoracocentesis, which is both a diagnostic one and therapeutic one, and intercostal pleural drainage, either by conventional method or by the trocar guided method, which is easy for the persons who are doing the procedure. And pigtail drainage, which is one of the most important procedure that all the pulmonologists should acquire a skill in that, because of late we are not putting a large bore drain for most of the pleural procedures, particularly for the patients with pneumothorax and also for the pleural effusion. We try to restrict the size of the pleural catheters or the pleural drain to be minimum, in order to avoid the hazard, in order to avoid the big scar, in order to avoid all the complications, in order to keep the drain in a particular hold in the chest wall. So it's always, as per the various guidelines, always better to choose a smaller drain, except for the very few situations like where we choose large pleural drain in case of thick fluid, like in case of empyema, or in case of hemothorax, where the blood clots will be there. You won't able to drain that blood clots with a small bore drain. So in that situation, we go for a larger drain, maybe 32 or 36. But otherwise, of late, we are using a small drain catheter. So for that, the most important tool for the drainage is pigtail drainage. And of course, when we are not successful in using all the conventional methods like thoracocentesis, intercostal pleural drainage, and pigtail drainage, we often go for a thoracoscopy. Thoracoscopy, usually by a pulmonologist, is of diagnostic purpose only, mainly in case of undiagnosed pleural effusion. After all our basic workup, if you could not come to a conclusion what the patient is having, then better to get a pleural biopsy. The best will be under image guidance, under direct vision. So the best will be with a medical thoracoscopy. So nowadays we are using thoracoscope for therapeutic procedures also, by removing the adhesions by adhesional lysis and all, and by just clearing the pleural space and making the lung to expand and peeling, and all these things can be done. But it depends upon the experience of the thoracoscopist who is performing the procedure. And the favorite thing for me is thoracoscopic lavage and brushing. So this concept actually, lavage, that we are doing for the past 3 years. And one of my PG, Dr. Pradhapan, is doing a thesis on this thoracoscopic lavage also. So he got a good yield when compared to the cytology. So what is the basic difference between lavage and cytology? Same thing. What we do in a bronchoalveolar lavage, we put a saline and we just suck it out with the suction. So by doing that, it will shed all the cells, inflammatory cells, all the malignant cells and all. So it will give additional yield. In addition to the biopsy, when you do a ball, you get additional yield. The same way when you do a pleural biopsy, in order to get additional yield, it's always better to do a lavage also. But in this case, pleura is actually a large space, not like a bronchus, like it is a small space where you put a small amount of saline and wash it out. But whereas pleura is a large potential space, and then we need to wash it with a significant amount of saline. And what we found out in our thesis also, like from our PG, is that even in even in cytology. Yeah. So even in cytology also, even in pleural fluid conventional cytology, after you go, if you are getting the fluid after aspiration, so that has a chance that you may get a negative result even the patient is having malignancy. But whereas in thoracoscopic lavage, after putting the saline into the pleura, you can make the cells to shed after the wash. So instead of already shedded pleural cells in the pleural fluid, you can have a fresh cells after putting a lavage that will give more yield when compared to the conventional thoracoscopy. And pleural
Are you
pressure, of
connected
course.
to Dr. Yuvraj? Dr. Yuvraj?
Yes, madam.
Just ask all the participants to mute their
Yes, ma'am. Yes,
microphone.
ma'am. Okay.
Because some disturbance is coming.
I request all the participants to please mute their mic so that everybody can hear what I am speaking. I want everyone to mute the mic, please.
931-454.
I want everyone to mute the mic, please. Okay. Okay, we'll go ahead. So like lavage, as I already told, so we have a concept of brushing also, which is another quite good concept. So the same way what we use in bronchoscopy, like bronchial brushing, there's a specialized brush is there. Through bronchoscopy, we use the brush and then we scratch over the area where we want a good yield. So that will give additional, exfoliative cytology results, which is almost helpful in arriving at a diagnosis. The same way in pleura, in addition to the biopsy, there are some areas where we may have a tough time to do a biopsy. For example, if you see a nodule which is very close to the lung, that is over the visceral pleura. So most of the times in medical thoracoscopy, what we advise is that you touch the parietal pleura, not most of the times visceral pleura. But even though we are doing a biopsy over the visceral pleura also, nothing is going to happen. Only thing is that when you take a biopsy from the visceral pleura, you may create a leak. You may take a biopsy from the lung piece, you get a air leak post procedure. So that we don't want to get. That's why we used to avoid most of the types. As a pulmonologist, our main concentrating area will be of parietal pleura, not a visceral pleura. So if at all, if you see any pathology in the visceral pleura, if you want to take a sample from that, so in that case, on the safer side, instead of pinching of the pleura along with the lung, you can scratch it over it. So, if you scratch it over it, so you don't see much of damage over the lung, much of leak over the lung, and it will give a yield also. So in that case, and for example, if you see a nodule very close to the vessel, large vessel or something like that, so in that case, brushing will be very helpful. Of course, biopsy we can do with the pleura and lung or any mass which is seen in the vision of thoracoscopy, you can do a biopsy. And these two things are very important. And pleural manometry, I think this manometry is not a new concept. This concept is there for many years. The problem is that like how far the clinicians are using this manometry is a big question. And we have a good system to assess the pleural pressure. One can ask one question, sir, why we want to assess the pleural pressure? This is very important because to differentiate whether the lung will expand or not. Because most of the times what will happen, there is a concept of trapped and entrapped lung. I think all PGs are aware of this. If you see any endobronchial obstruction in the bronchus, even after removing the fluid also, it won't give a much relief to the patient because the breathlessness is not only because of the passive collapse of the lung, it is also because of the endobronchial obstruction that is there in the patient. So that's why we need to assess how is the response of the lung, after doing a pleural drainage. To clearly assess that, it's always better to do a manometry, and doing a pleural manometry also helpful, also guide you to how much fluid you have to remove, because most of the times in textbooks you used to read when you drain more than 1 liter or 1.2 liters, it is always detrimental. You may have a re-expansion pulmonary edema like that thing. But when you have a pleural manometry, so you can easily assess that, like how far the pressure change is there, and you can very well avoid this re-expansion pulmonary edema, and that will be more useful for the clinicians. So that is one of the major use of pleural manometry. And of course, indwelling pleural catheters. So this is one of the fascinating area for all the pleural interventions. So indwelling pleural catheters gives you a freedom that, instead of keeping an ICD hanging over the side of the chest, the patient has to keep the ICD all along in case of chronic recurrent pleural effusion. Most commonly we put for malignant effusions. Recurrent collection is there even after all the procedures. And you can ask one question, sir. In case of malignant pleural effusion, there are two options. You can either close the pleura by doing pleurodesis, or you can do a indwelling pleural catheter, which is best. If you ask me, based on the various studies, so there is head-to-head comparison is there. There is not much of difference. So it depends upon the operator's experience. They can give an option of indwelling pleural catheters. They can give an option of pleurodesis. But one thing is that there are certain conditions where indwelling pleural catheters edges over the pleurodesis procedure, where there are certain conditions like in malignancy, if the patient is having a trapped or entrapped lung or any other situation where the lung is not going to expand, okay, where it is difficult for any person to approximate both the layers of pleura. For pleurodesis to be successful, there are two things. One is the two pleural layers should approximate each other, because pleurodesis is like a cement. So if you want to approximate two layers, the two layers should be close to each other. You can't approximate one collapsed lung and you put some paste like thing in the parietal pleura. It's very difficult to get approximated, and often it is a big failure for the procedure. So in order to give a good approximation, the lung should expand up to the chest, close to the chest wall, so that pleurodesis will be successful. Whereas in some situations where trapped lung and all, you may not get that much of expanded lung. So always is a failure. In that situation, definitely indwelling pleural catheters is very helpful for the patients with the recurrent pleural effusions. So thoracoscopy, as you know that, so we are going to deal in detail about thoracoscopy, because all the thoracocentesis, intercostal drainage and pigtail drainage and all are commonly we are using day-to-day practice. In fact, thoracoscopy is also a simple procedure once you know the the tactics. It's not such a complicated procedure to be done. It's very, very easy. So it is an old technique that is invented in 1910 by a Swedish physician named Jacobius. Its principal use in early years was to allow the operator to divide the pleural adhesions. You see that was initially used mainly for therapeutic purpose to remove the adhesions in olden days. By cutting or electrocautery, that we call it as pneumolysis in olden days, so that an artificial pneumothorax could be induced in a pre-antibiotic era for TB therapy. You know that all the rifampicin and chemotherapy played a major role for the control of TB era in India. But before that, there is one concept called collapse therapy. If TB lesion is there, the concept is that you collapse the lung by putting air outside the lung, by putting some artificial substance outside the lung, outside the pleura, subcutaneous space, and also into the peritoneal space. You make the lung to collapse. So that is considered as one of the therapy in olden days. In that days, they use thoracoscopy for that. Okay, so how do you call thoracoscopy? Because most of the times, if the name indicates, previously some 10 years back, thoracoscopy was very well performed only by surgeons, mainly by CT-based surgeons. That's why there is a debate whether we can call it as a medical thoracoscopy. So we are using the term of medical thoracoscopy since 1994. However, since the term thoracoscopy is still used to describe both medical and surgical procedures, always a confusion is there. To avoid the confusion, it is better proposed for us, sake of clarity, it's better to use the term of pleuroscopy that was used in France previously. The term pleuroscopy has now become quite popular with the introduction of semi-rigid, that is a semi-flexible flexure thoracoscope or pleuroscope by Olympus India or Olympus International. So today, both the terms, medical thoracoscopy and pleuroscopy, often used synonymous. Other terms that are used is thoracoscopy for physicians, thoracoscopy for chest physicians, but these two terminologies are commonly used. One is pleuroscopy, another one is medical thoracoscopy, because this thoracoscope is slightly different from what the surgeons are doing in VATS. Okay, one second. This picture I just put because nowadays thoracic surgeon have other area to flourish. We the pulmonologists have some areas, and we are going more in favor of interventions nowadays. So instead of giving a simple intervention to thoracic surgeon, at least the trained pulmonologist can perform all the procedures, and they are equally competent and potent enough to do the procedure for a simple thoracoscopy, nasolaris, and all these things. That's why they should find some other area to compete, and not in thoracoscopy and not in case of EBUS. Because most of the times when you do EBUS, when you discuss about the EBUS and all, they used to tell that EBUS is our area. So basically they should concentrate on mediastinoscopy and taking the biopsy instead of all this EBUS and all. I hear that EBUS are being commonly performed by thoracic surgeons also in Western countries, but I think that is a area for pulmonologists, and they should not interfere in that. So this is the basic difference between VATS, that is video assisted thoracoscopic surgery, versus medical thoracoscopy. As I already told you, video assisted thoracoscopy is performed usually by a thoracic surgeon, whereas medical thoracoscopy can be performed by any pulmonologist. The site of video thruster thoracoscopy is obviously in OT only, whereas medical thoracoscopy can be performed in a normal endoscopy suite where we are doing a bronchoscopy. And anesthesia, what we are using for video assisted thoracoscopy is general anesthesia, whereas mostly what we use is a conscious sedation. Of course, we use midazolam or something like that, and we use a local anesthesia only. And what are the types of mechanical ventilation? So what we use usually in VATS, they collapse the lung by using a W ventricular tube, or single lung ventilation is a common strategy that is followed for VATS. Whereas medical thoracoscopy, we allow the patient to spontaneously breathe, and we can speak to the patient, we can talk to the patient, and we can do the procedure, which is such a simple procedure. And we should thank the innovation for that. And number of ports what we put for VATS is usually a multiple ports we use. We use a triangular port like that thing, so that one port is used for vision, other ports is used for guidance of your instruments. One is for a holding, one is for cutting. So one port for vision, one is for holding, one is cutting. So this should be aligned in such a way that should be easy for surgeon assistants, so that the procedure will be very easy for them. Whereas medical thoracoscopy, usually a single port thoracoscopy, as we do a port for a ICD insertion, the same thing like a single port. Sometimes we may create a double port also, that I am going to show you in my videos. These are the common indications for VATS. Usually it is a minimal invasive surgery. When you see a resection of pulmonary nodule for evaluation of work for malignancy. When you see a bulla, you can do a bullectomy. You can staple the bulla raw area, and you can close the leak. And we can do a lung biopsy and lobectomy. Most of the times what happens, like in case of ILD, so what we are seeing in idiopathic intestinal pneumonia, IPF and all, now there is a conflict that whether we can go for cryobiopsy and VATS. So definitely VATS is a good option, like if the surgeon is very good. So VATS also will give a good yield for idiopathic intestinal pneumonias, along with, you can do a lobectomy also very well. Of course, there are some surgeons who can do pneumonectomy, and you can create a pericardial window. These are the things the surgeons can have a very good control over it. Of course, bulla also can be touched by pulmonologists. I'm going to show you some of the cases which are the cases we can touch. And indications for medical thoracoscopy includes a diagnostic or therapeutic, that is a pleural biopsy with chest tube insertion, TARC pleurodesis, and you can do adenolysis and delocalization. So one query is that, sir, always we have a doubt that like whether we can just check my phone. Yeah, sorry. Whether we can do a procedure with a bronchoscope, because most of the times, this semi-rigid thoracoscope is costing huge amount. So that's why we used to prefer rigid thoracoscope for that, because it costs only 2 to 3 lakhs only with all the accessories. But one thing is that rigid gives a feel that like a surgeon. Okay, so most of the times a new interventional pulmonologists and all, they feel somewhat reluctant to use a rigid instruments. But of course, both are simple, both are easy only. So can we use a bronchoscope as a thoracoscope? Yes, there are a lot of studies where we can use a bronchoscope as a thoracoscope, because we need a vision for that. So, so what is the main problem what we face while using a flexible bronchoscope is that, so there are several disadvantages. Mainly, they provide less adequate orientation of the pleural cavity. The field of vision is very important. So bronchoscope, you see a tunnel vision. So like a tunnel, like if you see the vision, it will be like, because that is meant for viewing only small area that is in the bronchus only. So whereas in pleura, the vision should be wide enough so that it can just show you, it should show you that parietal pleura, visceral pleura, so that will be a good orientation. So before performing a thoracoscope with a flexible bronchoscope, ideally you should know how it looks. So sometimes there will be a confusion. So the anatomy guidance is also very important. And moreover, most important thing is that most of the times the biopsy what we are taking with the flexible bronchoscope, even though with vision is very, very small. And era of semi-rigid thoracoscope, as I told you, Olympus is the thing that who brought semi-rigid thoracoscope. It was very successful in terms of giving a yield, which has a working channel of 2.8 mm and incorporated video imaging also. You can copy also. So definitely the maneuverability is very, very simple. So it feels like you are doing like a bronchoscope only. Only thing is that the proximal end will be hard enough to keep that rod into the area where you created space to enter the pleura. And then the tip is like a flexible one, so that with the lever we can, you can flex completely to see the superior aspect, inferior aspect, all these things. So this will be very easy, and the maneuverability is very good, painless procedure, and that is advantage. You can see this is So this is the semi-rigid thoracoscope by Olympus. You could see the handle is very well like a bronchoscope. You can see the proximal end is a rod-like thing. It's stiff and it won't bend. And you can see the distal end like our bronchoscope. So the channel is 2.8 mm as we use like a conventional scope. So what are the advantages? It looks a feel of a flexible bronchoscope, and it is helpful for psychologically, like we are not doing rigid, and for the newcomers, definitely the semi-rigid thoracoscope is very good. And the flexible tip can be maneuvered in different directions around the adhesions. You can break the adhesions. It facilitates the homogeneous insufflation of the talc. So when you're using talc, what will happen when the rigid thoracoscope, when you are using, so you have to bend the thoracoscope to just spray the talc over in different areas of the pleura. Whereas in flexible thing, you can bend it with a lever, and you know the pain that is applied to the chest wall, the pressure that is applied to the chest wall is very minimal, and the pain is also very less, and it is very comfortable for the patients, and that's why it is more preferred. It maintains a clear optical field by allowing concurrent suctioning, which is analogous suction techniques. So basically, what is the problem with the rigid thoracoscope? Sometimes what we see is that is fogging. Okay, so when you are putting a rigid thoracoscope into the pleura, what will happen? The fluid is there, and above that, you know, the air will be there. Definitely, obviously, air will be there. Empty space, air will be there. Fluid will be there, and then pleura we are seeing. So most of the times you see the fogging, and you have to, you know, dip it. You have to take the, you know, camera out. You have to dip it with the betadine or some solution. Once again, you have to keep inside. So that type of thing is not at all needed in medical thoracoscopy, and it is definitely helpful to keep the vision, live vision. And however, what is the problem with this even semi-rigid thoracoscope is that the specimens is slightly larger than a flexible bronchoscope, but it is smaller than the rigid scope. But as far as my experience is concerned, I use both rigid and semi-rigid. My experience is concerned, the size of the biopsy is doesn't matter a lot. Okay, so if you are taking in a correct position and you take a number of biopsies, more than 10 biopsies, both are equipotent, and yield is very, very good. Moreover, sometimes the rigid thoracoscope is very, very helpful in case of therapeutic procedures. When a lot of adhesions are there, in case of complicated paramedic effusion or in the case of empyema, if you want to break the adhesions, it's always good that you should have a large chunk of instrument into the pleural space. So that will be helpful. So in that case, for more therapeutic option, you can choose a rigid thoracoscope. For more diagnostic option, you can choose a semi-rigid thoracoscope. So I'm not telling that semi-rigid thoracoscope is also useful for therapeutic adhesions and all these things. So we can very well do with the semi-rigid thoracoscope also. We have a cartridge and all these things. Just directly you can just show the cartridge and you usually cut all the adhesions, which is also very simple. But we need all the instruments for that. So now next question is that who can perform the thoracoscopy? The thoracoscopy should be only undertaken by the properly trained respiratory physician, a minimum of 20 procedures. All these guidelines I'm just telling from the European Respiratory Society. They framed the guidelines for those who can perform the thoracoscopy. A minimum of 20 procedures desirable to achieve the sufficient familiarity instrumentation. I feel that only 2-3 procedures is enough. I feel, but you need to be, you need to have a backup at least from a trained person. So that's why it's very simple. And procedural competence can be probably be maintained if about 10 to 12 thoracoscope performed. But the European guidelines is very specific in that, because you need to have a continuous flow in your procedure techniques. So at least 10 to 12 procedures has to be performed yearly to be competent enough to do a procedure. So as I already told you, there are two instruments we can do, rigid and semi-rigid. And these are the ideal rigid instruments. You can see 0, 50 degree and all these things. Of course, what are the indications as a diagnostic thoracoscopy? So any patients who are having a pleural effusions of indeterminate origin. So most of the times we see pleural effusions, but most of the times often we don't prefer thoracoscopy as an initial modality of diagnosis. We do all the basic procedures. We differentiate whether the patient is having exudative or transitive effusion as per the criteria. And when the patient is having exudative effusion, the common causes of chronic pleural effusion, 3 things has to be ruled out: TB, malignancy, and CKD. All these things has to be worked out. If that is not fitting it with any of these diseases, and if you have a doubt with malignancy, then we can you can opt for a biopsy by using a thoracoscopy. And staging of lung cancer with the pleural effusion, of course, diffuse malignant mesothelioma, that is also there. Hormone receptor determination in breast cancer and culture in tubercular pleurisy. Staging of pneumothorax. In case of diffuse lung diseases, you can do a thoracoscopy by the biopsy. Localized chest wall lesions also you can do a thoracoscopy. What are the therapeutic indications to achieve a pleural symphysis? By doing a TARC pudraj, and TARC pudraj in pneumothorax to do a pleurodesis, and then paramedic effusion empyema for opening up the locules and to break up the adhesions. These are the absolute contraindications. So very important thing that So before knowing the indications, it's very important to know that what are the clear-cut contraindications for a thoracoscopy. This is very important, because before doing any interventional procedures, we should know when to touch, when not to touch. So this one is a lack of pleural space. That's very important, because before entering into the pleura, you should be very sure that pleural space is there or adequately there or not. I feel that 4 to 5 centimeters is enough from the chest wall, from the parietal pleura. That's enough to enter the pleura. But most of the times, this is not at all an indication for us actually. Those who are clearly experienced, even the lung is fully expanded also, you can do a thoracoscopy. I'm going to show you that. That's called dry thoracoscopy. We can wantonly puncture the lung with a needle. We can make the lung to collapse, or we can just put a trocar and open the pleural space and connect to the exterior environment so that we allow the air inside the pleura and then make the lung to collapse. There are different options are there, but it needs repeated procedural experience. As a new pulmonologists, they should not try. They should have a good pleural space before entering in the trocar into the pleura. And pleural thickening of unknown etiology, very important. Those patients who are having a fused out pleura, having a extensive pleural thickening and all, so you could not perform thoracoscopy very well, because if the patient has pleural thickening, obviously rib crowding will be there. So if rib crowding is there, it is very difficult for the trocar to enter. So there are some cases we found some difficulty, but even that also we can very well retract the rib, and we can put the trocar. That is also there. Suspected mesothelioma, where the visceral and parietal pleura is fused. This is the very thing. So in mesothelioma, we always have to be very careful, because sometimes what will happen, that is called we call it as a frozen chest and all these things. There are different conditions to get a frozen chest, and the mesothelioma sort of thing. The lung will be surrounded by a thickened peel of pleura, and both parietal pleura is conjoined together, and you don't see the space inside. And once you go inside the pleura, you get a confusion definitely. So in that case, with experience you can touch, but as a new person you should not do that. And the patients who are already done a pleurodesis, where you expect not adequate space is there, so in that situation also you should be very careful. So what are the relative contraindication? The patients who are inability to tolerate the lateral decubitus position, patient could not lie down that position, and then unstable cardiovascular hemodynamic status, and presence of uncorrectable hypoxemia despite oxygen therapy. And this is actually not a contraindication, it's a relative contraindication. We do for even hypoxemia also. Bleeding diathesis with the pulmonary arterial hypertension, refractory cough, drug episensitivity, and reduced health status of the patient. Okay, what are the investigations we do for a medical thoracoscopy? We do a basic CBC, platelet count. Obviously, we are doing to do a biopsy. We are doing some semi-invasive procedure. We should not want the patient to bleed. We should have a basic hematology workup, like thrombocyte level and coagulation profile, electrolytes, and renal function, glucose also. If the patient is having significant hypercapnia, for example, the patient is having a chronic type 2 respiratory failure in case of COPD, it is best to check this ABG before putting the patient on procedure. Because sometimes during the thoracoscopy, we used to sedate the patient, conscious sedation. We give accelerating dose of midazolam also. Sometimes midazolam will have a respiratory depression. So sometimes, that is detrimental if the patient is having baseline PCO of more than 60 and all. So sometimes they may go for CO2 narcosis after the procedure also. So that's why you should be very careful in doing the procedure for these patients. And just radiograph or CT scan is required. As far as we are concerned, that any patient with a moderate to massive effusion, it's not good to do a CT thorax, because CT thorax will not show underlying lung because of the massive effusion. It's always better to perform the CT thorax after the procedure. So we do ultrasound procedure. That's very, very important. Pre-procedure ultrasound is always recommended to know the level of effusion, to know whether adequate space is or not, to know adhesions, not much of adhesions or not, whether adhesions are, what can be done. That is the thing. And to locate where to put a trocar, very, very important. So that's why ultrasound is very important. So sedation for thoracoscope, for level 1 thoracoscope procedure, local anesthesia of intravenous sedation is adequate. So usually we use midazolam 1 to 5 mg administered in small doses. We start with 2 mg or 3 mg and escalate the dose, doing the procedure titrate according to the patient response. Other agents commonly used are fentanyl and alfentanyl. I think midazolam is common and safely used. Fentanyl also can be given. Okay, this is the thing that I already told you. Introduction of pneumothorax. So this is for dry thoracoscopy, where you don't see much of pleural space, but we want the pleural space to be created to play into the pleura with thoracoscope. So in that situation, we will make the lung to collapse. So for that, we can put a needle. So these are specialist needles. There are butene and various needle. I don't think this needle is available. I have not seen personally in literature only, in textbooks only I've seen. So what we commonly use only LP needle. That's it. Any needle, you puncture the lung, that's it. Lung will collapse. That's it. So provided that lung, if the lung is having some adhesions, it won't collapse properly. That is the only thing that problem with that. And these are the needles that I just told you. So during the thoracoscopy, what we really do, after aspiration of all the pleural fluid or induction of adequate pneumothorax, the thoracoscope is introduced in the pleural cavity to allow the direct examination of pleural surface. So what we see usually, there are two pleura, parietal and visceral pleura. So parietal pleura is attached close to the costal surface and the rib side, and visceral pleura is attached close to the over the lung. So both the sides you have to see. So you can choose any method. You can start from the apex, go to the costophrenic area and to the diaphragm, or you can start from the costophrenic area and diaphragm and go to the apex. So what I used to prefer is costophrenic area and diaphragm and apex. Why? Because most of the times for the thoracoscopy, indication is malignant diffusion. So what our experience and previous authors' experience also. So medical thoracoscopy most of the times yield good results when you take a biopsy very close to the diaphragmatic pleura. That's why in other terminology, what we can tell, the malignant nodules usually starts from the lower aspect in the lower costal surfaces that is close to the diaphragmatic pleura. That's why most of the times you go near, the patient is not tolerating the procedure also, they will take a biopsy and come out. That's the thing. So adequate assessment of diaphragmatic pleura and costophrenic rhesus is very, very important. Macroscopic and findings in the pleura to be noted. Like as we do in a bronchoscopy, what we see the mucosa, healthiness of the mucosa, whether it is a pale mucosa, whether it is a vascularized mucosa, whether it is a new vasculations there or not, whether it is hemorrhagic, whether the adhesions are there, so whether it is anthracotic pigmentations are there, all these things should be noted while doing a thoracoscopy. So let's start with a video. So this is a very good case. I'll just tell you, this patient is a 60-year-old male who presented with a recurrent effusion even after tapping. So the problem is that he was using Lasix also. He was having exudative effusion. So you could see, this is the parietal pleura. You could see the three strand-like line. So you could see the three strand-like, dilated radicals. Three radicals are there. So the otherwise pleura is shiny. This is the normal appearance of pleura. You see the pleura. I'll show you. This is the parietal pleura. That is, you can see the rib ridges also. The one that is interfering with this, it's a convex thing, that is a diaphragm. You see the diaphragm, it's contracting. Now this is a parietal pleura. We are taking a biopsy from the parietal pleura. Okay, so you could see, you can easily identify the parietal pleura. Basically, the rib edge will be there, along the rib edge inside. You can see these are the three lines. You could see the three longitudinal, dark red lines. These are nothing but the dilated venous radicals. Actually, why I just included this video is that, not much of thoracoscopy would have seen this finding, because, this is actually a case of patient with a cardiac failure. This was not worked up properly. Okay, this was the wrong report from the patient side, and it was a cardiac failure with a preserved EF. Actually, EF was normal. There is one entity called cardiac failure with preserved EF. A cardiologist also missed that. Actually, finally, we found out that, and we retrospectively did a NT, pro BNP, and all these things, and later turned to a cardiac failure with a recurrent collection. Of course, the effusion is unilateral and it's recurrent. That's why we perform the thoracoscopy also. Even with the safe hands, by thoracoscopy can be done in any sort of. So by seeing the venous dilatation, you could see there is a pleural venous congestion is there. So that is one of the clue for the patient. As far as this thing is concerned, the pleura is clean, soft, and shiny, as you see, except for the vascularity, what we see here. And you could see this is one more case. You could see the parietal pleura with a big mass. You could see the fluid that is there. You can see a big chunk of globular. It's a globular mass is there, with the daughter mass is there. Can you see that? It's very hard mass, and it is attached to the costal pleura. And the surface is okay, not very much vascular. And that's it. So once you, okay. So you could see there is a bleeding is there. So as far as the bleeding is concerned, actually thoracoscopy is very, very safe procedure. Like, one thing we should avoid is that, you should not take a biopsy very deep into the intercostal space. Always you just take a biopsy over the rib. Why we should tell is that, because of enthusiasm, when you put a biopsy set into the pleura, when you see the parietal pleura, when you take a deep into the intercostal space, what will happen? You will catch the vein structure, you will catch the vessel, vein, and artery. Sometimes, what will happen when you take a biopsy in a tortuous intercostal vessels, it may terribly bleed and the patient may die on the table. That's why most of the times we used to prefer biopsy over the ribs. So it is always good that over any hard surface, you kick the forceps and take the biopsy. It is very good for us to get a good yield, because behind that on bone is there. So if you take a biopsy, so the pleura will come easily. If you are not taking it in the bone, in between bone, if you are seeing the intercostal space, if you are putting the biopsy set, it will be somewhat risky. Okay, so the pleural biopsies should only be taken for the parietal pleura. A lateral lift and peel technique should be used. As far as the medical thoracosis is concerned, this lateral lift and peel is not at all useful. There is no need. Okay, you are seeing a directly lesion, you take that biopsy like a bronchoscope. Why you want to peel? So why they are telling is that pleura will be like an onion appearance. So when you take that, it will be like a sheet, but it is not needed at all. But if you want, you can do it. This technique gives you large size biopsy. Previously only I told you the size of the biopsy doesn't matter a lot. You take a lot of bits with a small biopsy that give it. Taking biopsy from sites overlying the upper border of front of the rib rather than intercostal space reduce the risk of hemorrhage. This is the point. You see that you should not take from the intercostal space. Repeated biopsy from the same site may penetrate sufficient deeply to damage the structure and should be avoided. This is one more case. You can see it's fully studded with a bee-like appearance. You see that? Whole parietal pleura is studded with a multiple fine nodule. So what do you think the diagnosis? You could see the heterogeneity of nodules. There are some nodules which are very smaller. There are some nodules which are larger, and the nodules which are conglomerated. So as you just give a report of thoracoscope, always the macroscopic findings you should always give a very clear idea, so that you know that will give a good impression for the pathologist also. That will give a good clue that what they are dealing with. So this case, we thought it is a malignancy, but finally it is CBNet positive and it is a tubercular pleurisy. So it looks very similar. So one thing that is somewhat against malignancy is that the lesions are very soft. You see that? So you could see the feel how it is coming. The chunk is coming. So 1 second. Now you see that? 1 second. It's very soft. Okay. Sometimes you may get soft nodules in malignancy also, but still we thought it is a malignancy, but it's look like pleury. So the differentiating point in the TB and malignant effusion is that the TB is a diffuse pleural disease. You don't see usually a normal pleura in TB. You see a chronic pleuritis like puckered appearance. Puckered appearance, like those who know Tamil, ammi kothradhu solluvaanga illaya, ammi kothradhu Tamil. So adu mari eppdinaka it will be like a puckered, like thickened appearance will be there. So that won't be there in malignancy. Malignancy is always a focal disease. You see nodule, adjoining to the nodule, you see the neovascularization, and next to that you see the normal pleura. So it is actually a patchy disease, not like what we see regularly. So this is one more case, a pleural nodule with anthracosis. You see that? This is a parietal pleura. You could see the nodule, and also you could see the thickening of the pleura. You see that the pleura is not shiny. You could see the ragged appearance of the pleura, and you could see the brownish pigmented appearance that is in the one of the nodule. We took a biopsy, and I'm just giving you one clue that if you see a blackish pigmentation in the pleura, anthracosis along with the nodule, that is more suggestive of malignancy. So you could see now, you could see a nodule that is just popping out in the parietal pleura, and adjoining to that there is some neovascularization. You see the vessels are there. There is some chronic pleuritis. You could not see that normal shiny pleura. Okay, and the nodule is slightly somewhat firm and hard, and you could see the black pigmentation. It is anthracosis. If you see a black effusion along with the dense black pigment, you could see this also having a black tinge. Okay, like a mole, like this thing, like a papilloma, all these things. So this is once again a case of metastatic adenocarcinoma. And once again, this is a case. You could see you could see the parietal pleura above here, effusion here, and you see the diaphragm. The diaphragm is moving up and down. You can see that, and over the diaphragmatic pleura, a lot of nodules are there. So this type of thing, manuality, you should not do, like what that was shown in the picture. So you could always go your thoracoscope very close to the area where to biopsy. So the biopsy set should not bend. Okay, this is the and you could see the glistening nodules are there along the intercostal space. And the point that is to be noted is that this patient have sparse nodules in the upper areas. I could see the nodules are more concentrated when you go very close to the costophrenic angle. This is the diaphragm, this is the costal pleura, and this is the costophrenic angle. All the nodules are concentrated more on the costophrenic angles, and the nodules, some of the nodules are conglomerated. And these patients also came as a malignant effusion. So in case of possibly a malignant pleural effusion, the tumor is not observed. Some authorities suggest that operator should consider obtaining the pleural biopsy from around the pleural plaques and anthracotic pigments. That's what I told. Although the studies of biopsy performed using a flexible fibroid bronchoscope recommend minimum 4 to 5 samples. We don't know how many samples has to be taken, but as per the European Respiratory Society guidelines, they recommend 10 to 15 specimen has to be taken from the biopsy. So you can ask one question, sir. You told a medical thoracoscopy with a single port. So what is the use of second port? Is it really needed? Yes, sometimes it may be needed, but it should not be tried with the new operators. Although many or most thoracoscopy can perform a single entry port, second port may be required in circumstances. So this port has to be done only when you have to have a control with the white channel. For example, the patient is having after biopsy bleeding is there. If you want to put a one more port, take a sponge into your artery forceps and then pinch over it. So these type of things can be done with a second port. So this is a very good case that we got. This is a young lady who came with a large cyst in the lower lobe. Finally, this patient was diagnosed as Burtock-Dubé syndrome. From us, we did a follicular gene mutation also. But she's young; she don't want aggressive procedure. So I just had a talk with our cardiac surgeon. He told that I'll help you. So these type of procedures always you keep the cardiac surgeon as a backup. So you could see a collapsed lung. This was more like a VATS. We did a medical thoracoscope by vision, and 2 ports also we did. And you see a cyst that is just there attached. You could see a cyst. This is the diaphragm, the lung, and you could see the rigid trocar that what we are seeing. This instrument is coming, and this is the cyst that what we are seeing here. And this cyst is somewhat thick also, gelatinous. So you could see the content of cyst. This is somewhat different. That's why actually Burtock-Dubé syndrome, pneumothorax, actually it's not quite very common like a lamb. So Burtock syndrome can present with a cyst, but definitely pneumothorax is much more common in lamb and compared to Burtock because of this texture of the cyst. And then you could see the content of cyst is very gelatinous liquid content. Obviously we think the content should be air, but here you see the cyst content. What we saw here is actually, so what we did is with the instrument we cut the cyst wall and then we break it out, and there is one. Yes.
Is it okay?
Yes, ma'am.
Is it okay?
Yes, ma'am.
Okay.
Can you see the screen, ma'am? No.
I can see you. I can't see the screen. I can see you.
1 second, ma'am. It was a technical error. Ma'am, can you just? I could not share the screen once again.
1 minute. 1 minute, Yuvraj. Can you see, Yuvraj, now?
Now you could see now screen.
I could see the screen.
Yes. This was the same. This was the same case. You could see the cyst. That Burtock and all. What I told you here, na madam. There is no problem, na.
We had only that video.
Okay.
And we are pinching that forceps, no? You are showing that content inside.
Okay. So you could see that the same case. You could see that cyst wall. It was grasped, and you could see the gelatinous content inside, and you could see that there is some gelatinous material that is there inside the cyst wall. So we removed that, and then with scissors, cyst wall is removed and then cauterized. So there was not much of leak post procedure, and post procedure the patient was stable, and then she is now also under follow up with us. And this is one more very good case. Actually, why I just put this video is that this is where therapeutic procedures how far the thoracoscopy is very useful. Here, this is a case, Devagi, who presented the multiple cysts in the lung. So what we thought, we do a biopsy. She presented with a pneumothorax, recurrent pneumothorax. So what we did, this is we have a doubt that whether it is a LAM or LCH. This is a female patient only. So what we did is that instead of doing a biopsy, instead of doing a bronchoscopy biopsy, why can't you take directly cyst wall? At the same time, we are very curious enough to see how the cyst looks like in LCH. Now let's have a video. You see that? You see the cyst or white glistening over the surface. This is a collapsed lung. You could see the pleura, you could see the trocar, rigid trocar, and you could see the multiple small cysts. Whole of the lung is with the cyst surface, and you could see when I go above, you see that such a large cyst, like the cyst is very thin, not like what we saw in a buttock. What we did is that the cyst we just removed, one cyst we removed and sent for biopsy, and which came as Langerhans osteocytosis, but unfortunately we lost the patient maybe after 2 months or 3 months only. It's very difficult. It is already a fully burnt out disease, like almost like all of the lung is replaced with cyst, and we gave an option of even lung transplantation also, but patient could not afford the procedure, and she could not follow that advice. This is one more interesting case where foreign body is also common in the thoracoscopy. So this is a patient from abroad, like Kuwait. He was working in Kuwait actually. So he came to us with, he told that, sir, there is one foreign body is there in the lungs. He just came with this history only. Then my assistants and my PGs actually saw the case, and Dr. Praveen only and Praveen Antanis were working out the case in my department. So they told me that, sir, there is one wire is there. There's a steel wire like thing is there in the, I think in the pleura only, sir, it is there. Then we asked the history. He gave that 1 month or 1.5 months back when he was admitted with a history of paraneumonic vision in Kuwait, in a government hospital in Kuwait. So where they did a procedure by Seldinger technique, they did a pictorial catheter drainage. After catheter drainage, once he went for a follow-up, they told that one piece is there inside. Then they told him that you have to go to cardiothoracic surgeon to remove that. But that fellow got offended, and then he just scolded them, and then he just came to India. And through one of my friend, actually, he came here. So he showed the X-ray. So X-ray was showing on 4 centimeter. 2 pieces of foreign body, one in the pleura, one in the subcutaneous space. So what we did is that under GA, we made the lung to collapse. Here the problem is that chronic foreign body is always difficult, not only in bronchus, in pleura also. Pleura is notorious. This actually, he was having foreign body in the pleura for more than 1.5 months. Now you could see how it is difficult. So I thought that, okay, I should not have done this procedure. But you could see the here, see there are a lot of, adhesions. I'll just show you the adhesions. You see that. You see thick adhesions are there between the parietal and visceral pleura. Lot of reactions were there, foreign body reaction. You could see the adhesions were there. Mainly because of this also, and the past history of paraneumonic vision. Both the things have contributed significantly to the patient adhesions, pleural adhesions. So in the presence of adhesions, very difficult to locate that 5 centimeter foreign body. It's a thin wire. I'll show you. Because what we did is that we kept a fluoroscopy also. By X-ray, I'm seeing the seeing the foreign body. But once you see inside, I'm not seeing, because inside is fully coated with all the adhesions. It's very difficult. So what we literally did is that we put a multiple port along with the thoracic surgeon. So we put a hand inside. Now you could see I'll just pass it. You could see the wire here. You see that? It was very thin wire. It was very sharp with the tip. And literally we palpated, and then through finger only just we could recover that. And finally, without major surgery, so the foreign body was removed successfully. Okay, that's one of the this is one of the largest interpleural foreign body removed till date. And this is one more case, that interpleural foreign body. Actually, it's iatrogenic. So this was as a pneumothorax. For a pneumothorax outside, they put a pictorial catheter. Okay, so pictorial catheter was put inside, and then after removing the pictorial catheter, during the time of discharge, okay, a piece of pictorial catheter fall into the fell into the pleural space, and then they discharged with the pictal catheter in the pleural space. So the patient came with the pneumothorax and with the pictal catheter inside. I was very shocked. And then here is a picture. You see that a pictal catheter is inside and it is just stuffed into the fissure, and you could see the diaphragm. Here is a fissure, this is a parietal pleura, this is a lung. You can see the lobes of lung and it is just stuffed into the fissure as a diaphragm. So with a single port we tried, you could see that the pictal is somewhat slippery. We could not catch with forceps. Then so it's very difficult, in a moving patient. You see that this patient we could not, we have not done under GA. Under local anesthesia, concentration only. The patient was literally tachypneic. You could see that. So, and with the movement of diaphragm also, anything which is close to diaphragm is always difficult, because always diaphragm movement will interfere our procedural techniques. You could see this is actually a basket that what we use for bronchoscopic procedures. So we tried to catch the tip, because the tip should go into the basket to catch the foreign body. Ultimately, we could not succeed in that. Then afterwards, what we did is that, because this is because of the movement of diaphragm. The diaphragm is moving heavily at a higher rate, so it's very difficult. So now after that, we put an additional port directly from the chest wall. We put under vision. We put a artery forceps. You could see the artery forceps. I kept over the diaphragm and then catch with the artery forceps and then remove the piece of pictal catheter. So that's also one of the good procedures. And the therapeutic procedure that what we can do is a pleurodesis and thoracoscopic pleural lavage. So this is a thoracoscopic talk pleurage. You could see. So the basic thing is that when you do a pleurodesis under a conventional method with ICD in situ, you don't feel that substance is equally distributed or distributed evenly in all the pleura. Sometimes in local data collection also is very difficult. Here under vision you can just spray the material inside, and that give a good symphysis after the procedure. So that is also useful with the thoracoscopy. This is set what we use for talc pleurage. So this is the catheter, and this is a plunger, and this is a plunger, and you can connect it, and then you can place the talc. So level 2 procedure, what I shown you, like that are some complicated procedures. You always have to keep some backup. You can ask for a CTV surgeon or those who are really experienced. You can do. Otherwise, you can simply do a diagnostic procedure that is well and good. And this already I shown you how we access the cyst wall in a Bartok-Dugas syndrome. This case, thoracoscopic adhesinolysis. You could see this patient have a lot of adhesions in the pleural space. This is the diaphragm. Lot of adhesions were there. So you can break the adhesions. You can use the forceps. See, you can use the forceps. You can use the forceps. You can pinch it. You can use a cautery. So whatever instruments we have, finally to remove all the chunks of diseased material, so that the lung will expand easily. So, and also it helps in the recovery of the patient. So the complication at the time of procedure, you could feel the pain, hypoxemia, hypoventilation may be there, cardiac arrhythmia, hypotension, hemorrhage, injury to the lung, other organs. So I feel that pain may be there, hypoxemia may be there, but all these things are somewhat rare. So most of the times, if you are doing properly, I think it should not happen. And the complications post-procedure, usually a re-expansion pulmonary edema, that's a headache once you drain a lot of fluid. That's why always used to prefer, drain the pleural space just 1 or 2 days before. Don't drain it completely at the time of thoracoscopy. So that's a thing. And pain, post-operative fever, wound infection, hypotension, empyema, subcutaneous emphysema, persisting pneumothorax, prolonged air leakage, particularly when you touch the visceral pleura, all these things may be there. And seeding of chest wall by tumor cells. Sometimes what will happen is mesothelioma, you can seed also along the trocar, and that's why you need to be very careful. And I already told you that thoracoscopic pleural brushing, this was our paper. This was a paper in one of the reputed journal from Poland, society. The concept of pleural lavage is therapeutic pleural lavage is performed by injecting a normal saline to the pleural space and aspirate at the time of thoracoscopy. This will provide a higher diagnostic yield, and cytological analysis of fluid obtained at thoracoscopy could provide additional diagnostic information for sure in addition to thoracoscopy. And one or two slides are remaining. This is very important. That's why I just want to concentrate on that. Pleural manometry. As I already told you, this is not a new technique. So the first measurement of pleural pressure by German internist like Heinrich in 1878. The lore of this procedure has evolved substantially. In the first half of 20th century, pleural manometry was an essential component of collapse therapy for patients with pleural tuberculosis or pulmonary tuberculosis. Interest in pleural manometry was renewed in 1980s after a study by Light and colleagues indicated that 3 different patterns of pleural elastance. You could see that how far the pleura is responding, So corresponding to normal pleural physiology, entrapment and trapped lung. So this is the procedure of pleural manometry, how we perform here. You could see it's a very simple procedure. You could see that this is a case of pleural effusion. Just for demonstration we did. This is actually a manometer very well. The medicine people used to use. This manometer is commonly used for this, see the CSF pressure. The same thing what we can use. You could see the swing based on the pleural pressure change. You could always see the pressure, whether what pressure the patient is having. Whether the patient is having intrapleural pressure is positive or intrapleural pressure is negative. So we could see that clearly. And after drainage, how much pressure is reduced also you can easily see. You can connect it with the catheter, you can see that. It's a very good and simple procedure. So pleural manometry has been advocated as a valuable tool to characterize underlying lung behavior during thoracosynthesis. It has been proposed to be useful in diagnosing unexpandable lung, predicting the success of pleurodesis, and preventing the development of excessively negative pleural pressure. That's why you could not drain so much. So much you create a negative pleural pressure that will lead to complications. So which in turn lead to the re-expansion pulmonary edema. So it's a simple and relatively safe procedure to perform and can be incorporated as a part of routine pleural fluid thoracosynthesis procedure. And we will do for some patients, not for all the patients. So normal pleural space, approximately 10 to 20 ml of fluid will be there normally, as you know. Normal pleural pressure varies between -5 centimeter of water at the end of expiration to -10 centimeter of water at the end of inspiration. With the presence of pleural effusion, the pleural pressures will become positive. As the pleural fluid is drained, the pressure will start to fall from the positive to negative side. So plotting the pleural pressure recording against the starting the pleural pressure recording against the cumulative pleural fluid removed gives us a pleural fluid elastance curve, which gives us information regarding underlying lung and the ability of the lung, whether the lung will expand or not. It's like predictability, like as we see astrology about our future. So we can see the future of the patient with the manometry. And in lung entrapment, opening pleural pressure is positive and starts to fall and reaches negative values with the fluid removal, but does not reach values less than -19 meter H2O. In trapped lung, so you can differentiate trapped and entrapped lung based on this. In trapped lung, the opening pleural pressure is negative initially only at the onset, so reaches further negative value with the progression. So in trapped lung, if already pleural pressure is negative, there is no point in removing the fluid. So that's why it's always better to see the pleural pressure. The pleural pressure recording can be done during thoracosynthesis by connecting an aspiration catheter and attached to the undamaged U manometer. That's what I shown you, the U manometer. Different manometers are there. So we can use a good U manometer and with the interposition of resistor to restrict the respiratory swings in order to obtain more accurate readings. You can use a CVP monitor also very well. You can use a glass monitor that is used in LP kit, that what thing. And digital handheld pleural manometer. It's a conventional, it's a commercially available pleural manometer. I'll show you like a SpO2 probe. So you see that how they are this measuring by connecting to the CVP line. And here this is very simple. This is actually a single use manometry that was marketed. So I also saw in ATS and ERS conference stalls. It's somewhat costly. And you could see by aspiration only, you can connect it, you can see how much pleural pressure is there. So always safe and you don't get much of chance of pre-experimental demand. This is the thing, elastance curve, that what we use. So you see the pleural pressure is marked along this side and pleural fluid removed is marked on this side. You could see this here, it is very drastic, fall in the pressure, negative pressure. Here there's a slow fall. Here the fall is just more dramatic. So this is much helpful. Last but not least is the intrapleural catheters, what we're going to discuss. Intrapleural catheters are being used for recurrent malignant pleural effusion as an alternative to pleurodesis procedure. They are very simple in place, can be placed on outpatient basis under local anesthesia. IPC uniformly relieve dyspnea and improve the quality of life in malignant pleural effusion. The original role of IPC was second line management tool. IPC was targeted at all the patients who had developed trapped lung, very important. So in case of trapped lung, where the lung won't expand, there is no point in doing a pleural test, because pleural test will be utter failure, because you could not approximate both the pleural surface. At those patients who have failed the pleural test in the past, so these patients, you can just give an option of intrapleural catheters. So collateral data suggests that overall spontaneous pleural test rate is around 45% of patients with a malignant pleural effusion. This is once again a patient with IPC insertion, one of our patients. It's a very simple procedure. You could see the guide wire that is passed with a needle. The guide wire is inserted by Seldinger technique, and along the guide wire, our PG is just making an incision along the side of guide wire. So for yeah, so now it's making incision. So now incision is there. See, actually, this is a big video. So only thing is that here the catheter is buried into the subcutaneous space. You could see that it's somewhat painful procedure only. I think we need to anesthetize the area, subcutaneous area. It's also a very simple procedure, very good procedure. Actually, it is very simple, and then it's good for the patient actually, except for the cost. It costs around 22,000. We use a rocket set of rocket set of indwelling pleural catheters, not that Pleurex one. Pleurex is still more costlier. Okay, you could see that has to snugly fit in the center, so that okay. So now it's ready now. Now you see that along the mount. So this is the trocar along the guide wire we are just putting. Now everything is subcutaneous thing is ready now. Now along the whole of trocar, we can just easily put that drain into the trocar and reach the pleura now. Now you could see the gush now. Now we just confirm the gush with the fluid. You see the gush now, and then after seeing the gush, you just put that into this thing, and then you peel it off, and then now it's ready. Now it's ready. In the same video. 1 second. You see that now everything is ready. Now it's just in position. You could see that you could not see the outside. Actually, this after drainage, you can just roll it out and then put it in the subcutaneous space. That's actually, it's a good thing. So that's the thing. So we also use indwelling catheters in hepatic hydrothorax also. That we recently published it in another journal. So this was our this thing in ERS last year. So ultimately, what you are going to do in a case of suspected malignant pleural effusion, with this slide, I'm going to end. So in suspected malignant pleural effusion, whether pathology is confirmed or not, you need to confirm. You need to see that when the pathology is confirmed, yes or no. So if it is yes, if the patient is having symptomatic dyspnea. If it is yes, so this actually a big thing. If it is not confirmed, what you need to see how to proceed for a tissue diagnosis. If symptomatic dyspnea is there, then you can do a small volume aspiration. If the patient is need a tissue diagnosis along with the dyspnea, along with the control of dyspnea, so you can prefer the 3 options: VATS, medical thoracoscopy, and of course, if you don't have a VATS and medical thoracoscopy, still you can do a pleural biopsy. That's what I used to tell to the PGs. Not all the gadgets you need. Whichever material you are having, you can do the procedure. So it's not a thing that all the interventional pulmonologists you are doing bronchial thoroplasty, they are great enough. It's not like that. Okay, every interventional procedure is simple. Only thing is that those who are having a sufficient knowledge, theoretical knowledge and practical skills, they are great than those who are doing because interventions, the thing is that by like chit chat, like like it's like training only. It's with available gadgets. If you have a training, it's like a driving car. Okay, there's nothing big deal in that. Okay, so basically you should know where to touch, where not to touch. And if you are not having this procedure also, ultimately what is the aim? We should make the diagnosis. So you can do a diagnosis very well by use the help of radiology. With the help of radiology, if the large mass is there in the pleural, you can do a image guided biopsy. You can do a ultrasound guided biopsy. That will also give a good deal. So basically, it's not only the intervention that you should do. So you should always see other options also, and be strong in your basics. That's more important. And be clear that why you want to do interventions. And definitely the safety of the patient comes first before doing all the interventions. And that's it from my side. Thank you. Thank you, madam.
Thank you so much, Dr. Yuvraj, for the elaborate and informative presentation as usual. I wanted to ask some questions here.
Yes, madam. Yes, madam.
You have written on hormone receptor reduction in breast CA. What is it?
Yes, madam. Actually, that ER receptor, this thing, like HER2 and ER receptors are there, madam. Like normally for breast carcinoma, they used to prefer hormone therapy, even for malignancies, hormone receptor therapy for malignancies. So those patients who are positive for hormone receptors, they have a somewhat good prognosis in case of breast CA. Sometimes the lesions are very small in the breast. You are hearing, ma'am?
I can hear. Tell me.
Sometimes the lesions are very small in the breast. Sometimes they may not catch the lesion, but this patient will have a metastatic pleural lesion. The most common problem what we see is that like breast carcinoma commonly presents a metastatic pleural lesion. So in that case, if the primary lesion is very small, if you do a pleural biopsy, in addition to the hormone receptor status in the breast sample, the tissue sample, you can do from the pleural sample also. That is largely helpful, ma'am. Yes, ma'am.
Okay. So that serves as a tissue for you.
Yes, ma'am.
Yes, then staging of pneumothorax. You have written a staging of pneumothorax.
Yes, madam. Yes, madam. Ma'am, the staging of pneumothorax for completion's sake only I have made, ma'am, because that staging was obsolete and it was the older staging. They used to do for like there are different 1, 2, 3, 4 stagings. 4 stages are there, madam. So that we do mainly with the rigid thoracoscope, mainly by surgeons. So as a completion sake, the guidelines they have made, that's why I made. But we don't do usually the staging of pneumothorax. So if the pneumothorax is recurrent, ma'am, what we do is that to identify the cause, we do a pleuroscopy to see that what is the reason for the recurrent pneumothorax. You can see the blub, you can see the bulla, blubs and all we can remove, ma'am. Yes.
Hello.
Madam. Yes, madam.
Can you hear me?
Yes, madam. Yes, madam.
Just a minute, Yuvraj.
Yes, madam. Yes, madam.
Hello.
Yes, madam. Yes, madam.
Can you hear me, Yuvraj?
Yes, madam. It's clear, madam. Yes, madam.
Oh, okay. Then one more thing, pleural manometry. What is you already showed us the instruments. What will be the cost like?
Ma'am, it is very simple. Like that U manometer is the thing that what we use in day-to-day practice with LP set. U manometer.
Dr. Yuvraj, I cannot hear you. Not
here, ma'am. One second. Can you hear me, ma'am, now?
Your volume is very low, Yuvraj.
Okay, one second. Can you hear now, ma'am?
Hello?
Can you hear, ma'am, now?
A little bit only. Still it is low.
One second, ma'am. Volume. No volume. Ma'am, actually, volume from my side it is okay, ma'am. I think unga side la I think edo irukku. Konja check பண்ணுங்க ma'am.
I don't know because
இப்ப கேக்குது ma'am, எனக்கு கரெக்ட்டா கேக்குது. Ma'am கேக்குதா ma'am? நான் பேச கேக்குதா ma'am?
இப்போ it's now it is okay, pa. Now it is okay.
Okay. Okay, ma'am. அந்த
approximate cost.
அதான் ma'am, இல்ல ma'am, manometer வந்து like manometer வந்து it's like a regular thing, like medicine people they used to do LP, lumbar puncture. For lumbar puncture actually there is one kit called LP kit is there. So in that U manometer is there. There are different U manometers are there in the market. So you preferably choose a manometer which is having more negative pressure, ma'am. Maybe up to -20. So in LP the problem is that the -20 may not be there. So it is hardly costs 250 to 400 rupees only, ma'am.
Okay.
Can you hear me, ma'am?
I can hear you.
It hardly costs only 250 to 400 rupees, not more than that.
Okay. Right. Thank you so much. Any questions from the audience? Anybody wants to have any clarification?
Sir, thank you, sir. For it was a very good, informative, and practically you have shown very good videos, sir.
Yes, thank you.
So it was a very good presentation, and you have brought in the pleural manometry concept also, which is a bedside procedure, sir.
Very simple, ma'am. Yes, ma'am.
So actually, this procedure room, sir, it is because it can be done either in the endoscopy suite.
Yes, madam.
All the and should we always have a cardiothoracic bag, sir, especially
No,
when we are
no,
doing
madam.
complicated procedures?
Only for level 2 procedures. Like I showed you, na, madam. Like bulla and this removal of cyst and removal of this thing. That procedure only we need a cardiothoracic backup. Whereas all the local anesthetic procedures and procedure under conscious sedation, we don't need a backup at all, ma'am. You can do. Nothing will happen. 100%.
Thank you, sir. Thank you, sir.
I think you can ask some questions. Fatima, you want to ask something? Hello, Dr. Yuvraj, can you hear me?
Yes, madam. Yes, madam. Madam, not able to hear me, madam. Ma'am, unga mic mute la irukku, ma'am.
Hello.
Yes, madam. Yes, madam.
Okay. Hi. It was a very nice presentation, Yuvraj, as usual.
Okay.
We thank you on behalf of our Respiratory Medicine Department and the CHRA. We thank you so much, Yuvraj.
Okay.
I think if there are no questions, I think anything you want to add?
No, ma'am. Anything, if you want to have a workshop and all, ma'am, I'm very interested.
Yeah.
Workshop, definitely I'll come.
Yeah.
No problem.
Yeah, definitely. We will be inviting you again for the workshop, I think.
Okay. Okay.
Very nice collaborating with you, Yuvraj. Thank you so much.
Thanks for
If
inviting.
there are no questions, then I think we will leave it.
Okay, ma'am. Okay. Thank you, ma'am. Thank you.
I think you should have it, Yuvraj.
Ma'am?
Since you are a host. Okay, you can leave, I think.
Okay, ma'am. Okay.
If there are no questions, thank you so much.
Thank you. Thank you, madam.